Good morning everyone. I am presenting a lecture on hydrocephalus, a very important topic in neurosurgery. Hydrocephalus is from Greek word hydrocephalus, from hydro plus cephal means head. Definition: an abnormal increase in the amount of cerebrospinal fluid within the cranial cavity that is accompanied by expansion of the cerebral ventricles, enlargement of the skull and especially of the forehead, and atrophy of the brain. This is normal and this is hydrocephalic MRI picture. Hydrocephalus is an abnormal enlargement of the ventricle due to an excessive accumulation of CSF resulting from a disturbance of its flow, absorption or uncommonly secretion. The normal volume of CSF is 140 ml. CSF is produced by the choroid plexus in the ventricles at a rate of about 500 ml in 24 hours. Overview of CSF production. The CSF volume of an average adult ranges from 80 to 160 ml. The ventricular system holds approximately 20 to 50 ml of CSF. CSF is produced in the choroid plexus at a daily rate of 14 to 36 ml per hour. This is a picture of an hydrocephalic child. The CSF flows from the lateral ventricle through the foramen of Monro into the third ventricle, via the aqueduct of Sylvius into the fourth ventricle, and then through the foramina of Megendi and Lashka into the subarachnoid space and basal cisterns. It flows over the cerebral hemispheres and is largely absorbed by the arachnoid villi of the dural sinuses. Mechanisms of increased intracranial pressure. Brain, blood and CSF are held in an inelastic container, that is the cranium, vertebral canal and dura. Changes in volume of either element, brain, CSF or blood, is at the expense of the other two. These are the ventricles, the CSF, the spinal cord. Classification: obstructive hydrocephalus, when there is an obstruction to the flow of CSF through the ventricular system. Communicating hydrocephalus, when there is no obstruction to the flow of CSF within the ventricular system, but the hydrocephalus is due either to obstruction to CSF flow outside the ventricular system or to failure of absorption of CSF by the arachnoid granulations. Causes: obstructive hydrocephalus, lateral ventricle, can be thalamic gliomas, third ventricle, gliomas or colloid cyst of the third ventricle, aqueduct of Sylvius, primary stenosis or secondary to a tumor, fourth ventricular, posterior fossa tumors, medulloblastoma, ependymoma, acoustic neuromas. Communicating hydrocephalus, obstruction to flow of CSF through the basal cisterns, failure of absorption of CSF. The most common cause of communicating hydrocephalus are infection, especially bacterial and tuberculous, and subarachnoid hemorrhage, either spontaneous, traumatic or postoperative. This is an MRI picture, CT scan. This is a CT scan of a patient showing hydrocephalus. Presenting features: hydrocephalus in infants, 3 to 4 per 1000 births. The most common congenital cause is stenosis of the aqueduct of Sylvius. This is a major cause of hydrocephalus in children with spina bifida and myelomeningocele who also have a Chiari malformation. Congenital atresia of the foramen of Lashka and Megendi, Dandy-Walker cyst, is a rare cause. The acquired forms of hydrocephalus occur most frequently after intracranial bleeding, particularly in premature infants, in meningitis and because of tumors. Aqueductal stenosis. The normal aqueduct measures about 1 millimeter in diameter and is about 11 millimeter in length. It is the most common cause of congenital hydrocephalus, 43%. Aqueduct develops about the 6th week of gestation. Male is to female is 2:1. Other congenital anomalies, 16%. Thumb deformities, prognosis 11 to 30% mortality. The major clinical features in infants are failure to thrive, increased skull circumference, tense anterior fontanelle, cracked pot sound on skull percussion, trans-illumination of cranial cavity with strong light, when severe, impaired conscious level and vomiting, setting sun appearance due to lid retraction and impaired upward gaze from third ventricular pressure on the midbrain tectum, thin scalp with dilated veins. This is a picture of congenital hydrocephalus. Enlarged head, brain with normal ventricles, brain with enlarged ventricles. This is meningomyelocele. Another photograph. Adult hydrocephalus, either acute or gradual. Acute onset adult hydrocephalus. This type of presentation occurs particularly in patients with tumors causing obstructive hydrocephalus. The major presenting features are due to the signs and symptoms of raised ICP as described earlier: headache, vomiting, papilledema, deterioration of conscious state, upgaze will often be impaired due to pressure of the dilated third ventricle on the superior colliculum of the tectum. Gradual onset adult hydrocephalus. The symptoms of raised intracranial pressure are only very gradually progressive and late diagnosis is common. Early features in the adolescent involve deteriorating school performance as a result of headaches, failing mental function, memory loss and behavioral disturbances. Endocrine abnormalities, progressive visual failure will occur secondary to papilledema and optic atrophy. In elderly patients, a chronic form of hydrocephalus is called normal pressure hydrocephalus. Radiological investigations. If the lateral ventricles and third ventricle are all very dilated and the fourth ventricle is small, it is likely that the obstruction is at the level of the aqueduct of Sylvius. An enhanced CT scan or MRI will help determine the cause, as it will better define the presence of an obstructing tumor. In a communicating hydrocephalus, all the ventricles are dilated. CT scan, magnetic resonance imaging, ultrasonography and plain X-ray skull. These are the pictures of MRI. Treatment. In general, the treatment of hydrocephalus is a CSF shunt or a third ventriculostomy. If there has been rapid neurological deterioration, this will need to be performed as an emergency. If the hydrocephalus is due to an obstructing tumor that is surgically accessible, resection of the mass may lead to resolution of the hydrocephalus and a shunt might not be necessary. CSF shunt. The usual method of CSF diversion is a ventriculoperitoneal shunt, in which a catheter is placed into the lateral ventricle and is connected to a subcutaneous unidirectional pressure regulated valve, which is attached to a catheter threaded subcutaneously down to the abdomen and inserted into the peritoneal cavity. Modern valves can have their draining pressures adjusted percutaneously, and shunts are being developed allowing intracranial pressure to be monitored percutaneously. This is a photograph showing the point of entry. This is the way the shunt is placed. VP shunt under the skin. Ventricle catheter, the CSF flow, peritoneal cavity. The surgical pictures. Postoperative care. The postoperative management is similar for any intracranial procedure. Initially, the patient is nursed flat to avoid rapid decompression of the ventricular system. Deterioration of neurological state or failure to improve will require an urgent CT scan to confirm that the catheter has been placed accurately into the ventricular system and to exclude the possibility of intracranial complications such as intracerebral hematoma. Complications of ventriculoperitoneal shunt. The major possible complications are infection of the shunt, obstruction of the shunt and intracranial hemorrhage. Other CSF shunts: ventriculoatrial shunts, ventriculopleural shunts, lumboperitoneal shunts. Third ventriculostomy. Using an endoscopic technique, a ventriculoscope is introduced into the lateral ventricle via a frontal burr hole and advanced through the foramen of Monro. The floor of the third ventricle just anterior to the mammillary bodies is then fenestrated, allowing CSF to bypass any obstruction in the CSF pathway and be reabsorbed by the arachnoid villi. Arrested hydrocephalus. This is a state of chronic hydrocephalus in which the CSF pressure has returned to normal and there is no pressure gradient between the cerebral ventricles and brain parenchyma. It is uncommon and is most likely to occur in communicating hydrocephalus. The patients, often children and adolescents, should be followed carefully. If there is any deterioration of those parameters, a shunt will be necessary. Normal pressure hydrocephalus. The gradually progressive classic clinical triad consists of dementia, ataxia, incontinence. The syndrome is progressive and the disturbance of gait, which may be the first and most prominent symptom, is more of an apraxia than a true gait ataxia. Thank you so much.